It's a pleasure to be here. I'd really like to thank the organizers for inviting me. What I wanted to talk about was guidelines. And practice guidelines, I have to say this at the beginning because it's so obvious, but it amazes me how many people forget that guidelines are really a reflection of the literature. So these are things that are published and presumably evidence-based. Now, there is a little bit of subjectivity to guidelines, but in general, people that put the guidelines together try and minimize the subjectivity. I'll start and say that I don't have anything to disclose. Nobody will give me any money for anything. So, to go back, over the last 10 to 15 years, the Society of Thoracic Surgeons has felt that it was necessary to get into the practice guideline business. The cardiologists have done this long before we ever started, and it became apparent that there were certain things that were unique to the surgical aspects of cardiac disease that were worthy of guideline development, and certainly blood management and blood conservation was one of them. So in 2007, we published a guideline about blood management in cardiac surgery. And in that guideline, we made 61 recommendations. Now, you realize that for the purposes of guidelines, we rank the evidence. And these rankings are based on the strength of evidence, and randomized, controlled, double-blind trials are the best evidence, and those are considered class 1. And then other observations are less strong, and they're less strong based on what's available in the literature. So, for example, class 2 recommendations are those that are generated from observational studies and not randomized controlled data. And then class 3 recommendations in general are those things that aren't recommended. So there may be some randomized trials here, but the randomized trials show that these things don't work, whatever they are. And importantly, in order to be a class 3 recommendation, it has to not only not work, but it has to cause harm. So things that are class 3 usually have no evidence base for supporting that intervention, but also may cause some harm. So for the 2007 version of our guidelines, there were 6 level 1 or class 1 recommendations, and they're listed here. Things like identifying high-risk patients before operation, and blood transfusion algorithms supported with point-of-care testing, and then a multimodality approach as opposed to a single intervention. And these are things that have high levels of evidence in the literature and that you can legitimately put together and support with a class 1 recommendation. And then there are things with lesser amounts of evidence, and for some reason the class 2 recommendations are broken down into 2A and 2B. But for example, stopping Plavix 5 days before operation was a class 2A recommendation based on available evidence in 2007. And things like factor 7 and retrograde priming and autologous hemodilution, things like that had some evidence base, but it was not nearly as strong as it should be, and those are class 2B recommendations. And then the class 3 recommendations. So remember, these are things that don't work. So, for example, if you reinfuse blood right out of your chest tube back into your vein, not only doesn't it limit blood transfusion and limit bleeding, it may do some harm. So when you give that blood back, there's bacteria in it, there's thrombin, there's fibrin split products, there's a whole bunch of bad things that you shouldn't get, and that's justified a class 3 recommendation. And same for PEEP and so forth. And dipyridamole, you realize, was given along with aspirin before operation, and it was thought that that would do something called platelet anesthesia. Well, not only didn't it do platelet anesthesia, it made you bleed more. So it's one of those things that's not indicated, doesn't limit blood transfusion, and it may cause some harm. So hence a class 3. So that's the 2007 version. Now what I want to do from now on is listed on this slide. So I want to go over the new things that we've come up with in the upcoming 2010 version. So I'd emphasize this hasn't been published yet. And one of the things I'd like to do is get some feedback from as many people as possible. I have to tell you that in order to get these things published, you can't imagine the amount of scrutiny that goes into this. So professional societies scrutinize this, the Society of Cardiovascular Anesthesia, the perfusion groups, all the members of the Society of Thoracic Surgeons get the guidelines electronically before they're ever published for their comments. And so part of my job, painful job, was to go over all these comments and sort of add or subtract or modify the recommendations based, and some of the comments were very, very good. So I hope if I start talking fast, it's because I want to finish early so I can get some feedback and hear what you have to say about some of these recommendations. And then what I'd like to do is sort of present some of the clinical scenarios where these guidelines might be applicable, a real-world patient type thing. And then along the way, I hope you'll understand and find out how the guidelines are actually developed. So what are the strategies for blood conservation? And really, between 2007 and 2010, there's not much difference. So in 2010, we felt that preoperative risk assessment was important. We felt that in 2010, there's some new information about various blood derivatives. So, for example, the last speaker was talking about fibrinogen product. Well, there's some other products out there that are potentially helpful in blood conservation. That new evidence was incorporated into the revision. And then there's some new things about blood salvage, minimally invasive techniques, and perfusion techniques that are worthy of including into the revised guidelines. So I'll start with preoperative assessment, risk assessment. So the interesting thing is the preoperative risk hasn't changed. The thing that's changed is the patients are sicker and older and more decrepit, but there are still the assessment of these patients as far as their risk is concerned is the same. The patients are old, they're on drugs, they're on antiplatelet drugs, they have comorbidities, they need urgent operations that are more complex, and so those things haven't changed. So of all these risk factors, what can you modify? How can you change their preoperative risk? Well, unfortunately, there's not too many things. So you can't make somebody younger. You can't change the operation. You usually can't change the urgency. But you can change two things. One is the blood volume. So really, blood volume is a surrogate of how much blood you start with. So if you're small or you're anemic, you have a low blood volume. You have a low red blood cell volume, which is an index of your red cells. And there is a way to modify that. So erythropoietin, even in a short course, is something that can be beneficial. And then the antiplatelet drugs are clearly a target for intervening in the preoperative risk. So the one thing that hasn't changed over the last 30 years is the profile of transfusion. So this is a typical one of 4,500 patients who had operation using the heart-lung machine. And this is the units of blood transfused and the number of patients who received this number of units. And this is amazingly consistent. And if you go back and look at your blood pattern, your transfusion profile, I bet you'll find something similar to this. So a lot of patients don't get anything. They don't get any blood transfusion. However, when you come up here, there's about 80% of the blood products that are consumed by about 10 to 20% of the patients. And that is an almost uniform observation amongst many, many programs. And that hasn't changed. Furthermore, the fact that if you get a lot of blood products, you have a bad outcome that hasn't changed either. So for example, if you get around 10, 20, 25 units of blood, and these are donor units, so a donor unit is either 10 donor units is 1 10-pack of platelets from 10 different donors. One donor, one red cell is 1 donor unit, 1 fresh frozen plasma is 1 donor unit. But if you get 20 donor units, 1 in 2 of those patients will have a bad outcome. So what's a bad outcome? Well, death, MI, stroke, renal failure, mediastinitis. So transfusion of large amounts of blood is a bad deal, and that hasn't changed. Between 2007 and 2010, there were more studies that reaffirmed the same risk factors. So here they are sort of summed up: age, blood volume, drugs that you're on, comorbidities, and the type of operation. These are still consistent preoperative risk factors. So surgeon's view, caveman's view, there's 2 things. There's patient factors and there's procedure factors. So the patient factors we just talked about: age, blood volume, comorbidities, drug, and then the procedure-related factors. So the type of operation, how long it takes, the urgency of operation, and then this imponderable surgical site bleeding. So what I really mean by that is individual practitioners influence outcome. And I'm not talking just about surgeons, although everybody knows that in your practice there's some surgeons that have more bleeding and some that don't. There's also some perfusionists who have more blood transfusion than others. There's also some anesthesiologists who have more transfusion. There's also some ICU intensivists who have. So there's no question that there's individual variation that contributes to bleeding and blood transfusion. It's impossible to measure it, but it's there. Can't deny it. So how does this work? Well, here's 2 of the most important risk factors: age and red blood cell volume, on the same axis, and then the number of units transfused. So, for example, a 75-year-old, 55-kilogram woman who's a little bit anemic has a low blood volume and is old, and that puts her right in this area. So just because of those 2 factors, that patient has around a 6-8 unit risk of bleeding before they even do the operation. So let's talk about a typical patient, okay? And this is a clopidogrel, the devil's drug type patient. So 80-year-old woman, you're called to the cath lab, and it's one of those stories where every word out of the cardiologist's mouth is worse, okay? So she's a little bit, she has left main disease, she needs an operation. Oh yeah, by the way, we just gave 600 of Plavix. And then, oh, by the way, she's got a little bit of renal failure, and she's hypertensive, she's diabetic, on and on and on. Oh, and she's anemic. So there's some questions about this patient that you can ask, legitimate questions. Is this a high-risk patient? What do you do about the drugs, the antiplatelet drugs? And what are the options to limit bleeding in this patient? So first question, is this a high-risk patient? Well, hell yeah, this is the prototypical person. This is, if you don't say this is high risk, then you've never seen high risk, okay? This patient has everything. She's old, she's anemic, she's got a low blood volume, she's got comorbidities, needs an urgent operation. So this ought to, set your risk factors on fire here. And that hasn't changed in between the guidelines. So how do you do this? How do you manage these risk factors in this high-risk patient? Well, as I said, there's not too many things to change. One of them is the drugs that you're on. And so antiplatelet drugs are a reasonable place to start when it comes to guidelines and figuring out how to manage these patients. There's a lot of evidence available, a lot of published evidence. It's a common problem, so it's a reasonable thing to write a guideline about. First question is, do antiplatelet drugs cause bleeding? Well, yeah, God, every one of them. I mean, there was a day in the old days, 30 years ago when I started, that aspirin was looked at as bad. Now, geez, the list gets longer and longer. And so, the new guy on the block is ticagrelor, prasugrel, I imagine there'll be a day when we say, gee, I wish it was just Plavix. You know, there'll be something else. Because the list is expanding, and each one gets more potent and more bleeding. So way back when, we had a guideline about aspirin, and aspirin is kind of a benign drug, and it's also a very helpful drug. And so in 2005, we had a recommendation to stop aspirin only in very low-risk patients. So everybody else should pretty much be on aspirin. And there's a reason for that. Aspirin's really good. It's the best you can do for somebody with a non-ST elevation MI. And then came Plavix, and so there were some more guidelines about that. And the and the AHA and ACC and the STS recommend stopping Plavix for 5 to 7 days before operation. There's lots of evidence now, and in fact there's more studies, so maybe as many as 15 studies that suggest there's increased bleeding with Plavix. The evidence is more compelling than for aspirin, but it's less good evidence. There's not a whole lot of randomized controlled trials, but still it's pretty solid. And then comes prasugrel. Okay, so Triton is the name of this study that was used to get approval for prasugrel. And this is some of the data from that study. And I'd ask you to focus on this. So this is Cabbage-related bleeding in patients treated with prasugrel instead of Plavix. So there's a 4 to 5-fold increase in bleeding, Cabbage-related bleeding, associated with prasugrel. That's a little scary. But, you know, the cardiologists say, listen, anybody with a non-ST elevation MI, if you give them prasugrel, they have a 20% risk reduction. You hear that all the time from the cardiologists. What does that mean? Well, it's important to know that, to know what it means. So if you have a non-ST elevation MI and you get a placebo, it means you don't get anything, no aspirin, nothing. 22% of those people are dead in 1 year. Dead from death, MI, stroke, whatever. They have some bad outcome at 1 year. Aspirin reduces that by 50%. So in other words, you have to treat 10 to 20 patients with an aspirin tablet to get benefit from that. All of these other things, clopidogrel, prasugrel, ticagrelor, reduce the risk by 20%. So the cardiologist will say, oh, there's a 20% relative risk reduction. Well, what that really means is you go from 12% to 9 or 10%. So you have to treat 60 or 70 patients with ticagrelor to get the benefit to a patient. Well, of those 50 or 60 patients, some of them might need an operation. Guess what? You'll have a lot more bleeding than 20% relative risk reduction. If surgeons had to live with a 20% relative risk reduction, we wouldn't do operations. See, if you had a difference in mortality between those, you had to treat 50 people to get 1% change in risk. That's cardiologists buy that, but surgeons don't. So it's a matter of looking at of how you look at it. So here's the data for aspirin, just to sum up what I just said. So this is the placebo curve. So at 1 year, there's about a 22%, something like that, death, MI, stroke, if you have a non-ST elevation MI. And aspirin cuts that in half. Aspirin is the best thing you can do for somebody with a MI. So whenever you start giving these drugs, and the last speaker talked about this, and it's important to understand it. When you start giving these drugs, there's a variability in response. It so happens that there's not much variability with aspirin, but there is some. So here's an example of that. So this is bleeding time measured after aspirin. So if you start before aspirin, the average bleeding time is around 5 minutes. On day 1 after aspirin, the bleeding time goes up a little bit, not very significant, about 6 minutes. But every time you do this, there's this outlier. That person has a bleeding time of 16 minutes or 15 minutes. Guess what? if you do an operation on this patient, he's going to bleed or she's going to bleed. So that kind of variability shouldn't surprise you. Everything we do has that kind of variability associated with it. Some variability is greater, some is less. Somebody once told me, and I assume it's true, that in the conduct of an operation, like an open heart operation, there are 500 interventions. So imagine if there are 500 things that you do to a patient, and each one has this kind of variability with it. Well, that's a pretty significant. You're bound and determined to have some variability in the outcome of these patients. So, in our hypothetical little old lady, can we stop antiplatelet drugs? Well, the answer is really uncertain, but the bulk of evidence suggests that you should stop antiplatelet drugs, maybe not aspirin, but all of these other things. And this is a side effect of guidelines. So often when you look into something, you find out, gee, I wish there was a randomized controlled study about Plavix. Well, most of the guideline recommendations come up with something like that. There's a little bit of uncertainty associated with it, and these are what we'd call hypothesis-generating guidelines, and that's a side effect of the guideline development. It identifies knowledge deficits. So what are the blood conservation strategies? So here are the sort of the differences between 2007 and 2010. Within 2010, there are some new blood derivatives that are available. There are some changes in the blood salvage techniques. Minimally invasive techniques have become more and more common, and now the risks of bleeding are being studied in these minimally invasive procedures. There's some new perfusion interventions, and maybe there's some not so new but sort of rethinking some of the perfusion interventions. And then there's sort of a proliferation of various topical hemostatic agents. And all of these things are things that have been included in the revision. So the sort of thumbnail view of the 2010 guidelines is listed on this slide. So the off-pump procedures and endovascular procedures have pretty much shown significant savings in blood utilization. Aprotein is gone. Lysine analogs are here to stay, appear to be safe, have efficacy in terms of limiting fibrinolysis. And then there are lots of perfusion interventions, which we've included in the 2010 version. Most of the benefit is what I would call variable. And this is variable means there's not a whole lot of randomized, double-blind, placebo-controlled trials, and so the strength of the recommendations is not good, class 2B in general, but summed up probably have a pretty significant benefit. So to give you a sort of a overview of what works for blood conservation, I sort of pointed to three things. So one is multiple things work better than a few favorite interventions. And I would go around and give talks, and people would say, well, gee, we do this all the time, and it works. It's what makes our patients not bleed. Well, I would submit to you that it's not one thing, it's multiple things. And that's pretty supported in the literature. Then the other thing that I think is really well supported is that if you don't know how much bleeding you have, you'll never make it better. So the first thing you have to do is measure it. And that's a principle called total quality management. And it's going to appear in the 2010 guidelines, but it's also in the 2007. And measurement and management are key features of any blood conservation program. And then, as I mentioned, the outcome in terms of blood management and blood conservation is the sum is often greater than each of the individual parts. And so here's examples of some of the things that if you look at these things, normal bulimic hemodilution, mini circuits, biocompatible circuits, none of these things are really what I would call class 1 evidence. But if you sum these up, if you use them all together, then you end up having a very significant benefit. So an example of that. So here's a review of the literature of normal bulimic hemodilution. So we found when we did this 5 prospective randomized trials that addressed the question of does normal bulimic hemodilution reduce blood transfusion and provide a safe outcome. Well, 3 of the studies showed no benefit. 2 of the studies showed a benefit, and it's not possible to do a meta-analysis of all these studies because they all used something different. Somebody used a different volume, a different patient mix. You know, there's a whole bunch of variability in this. So it really is impossible to come up with a consensus, except, and there's contraindications. But this may be beneficial as part of a multimodality program. And so this was given a Class 2B recommendation individually, but again, summed up with other interventions, probably has some benefit. So one of the things we looked at was transfusion of plasma. Plasma is way overused. In our place, and I don't say, I don't present these guidelines and claim that at our institution we do all these things, because we don't. We're just as bad as everybody else, or as good as the case may be. But so, for example, anybody who came into the recovery room and their INR was a little bit prolonged would get some plasma. Well, that's probably inappropriate. It's not specific enough. There are some indications for plasma, but it is way overused. So when we reviewed the literature about transfusion of plasma, there were some pretty good concrete indications. So serious bleeding with a specific coagulation factor deficiency. So reversing warfarin in somebody who's bleeding. Plasma has a role there. And then massive transfusion. And trauma literature now has sort of gotten into this, but it certainly applies to the bleeding cardiac surgery patient. And there's a probable benefit from, if you've had a massive transfusion, it used to be every 4 units of red cells you'd get 1 unit of plasma, and it's probably better to get more plasma in that setting. And then things where plasma is not indicated. You know, it's not indicated just because you think somebody's bleeding. It's got to be more specific than that. And then if somebody needs to have their warfarin reversed and they're not bleeding, then it's not indicated. You realize plasma half-life is much shorter than warfarin, so it's not a reasonable transfusion method. So then the antifibrinolytic drugs, you know, no longer do we have aprotenin. But the evidence is out there to support the use of lysine analogs. It is a Class 1 indication. There's a fairly large number of randomized controlled trials. It reduces blood transfusion and re-exploration, especially in high-risk patients. Aprotenin is gone in the U.S., but actually is being used elsewhere in other countries. And so it still is a very effective antifibrinolytic agent. It reduces blood transfusion, but it has some associated side effects, including renal dysfunction, possibly increased mortality. So there are also some newer blood products which are available and have some efficacy. So I'm not sure, I had to look into our blood bank to see if we used leukoreduced red cells. And it turns out we do, thank God, but there's some pretty good evidence that by using red cells that have been freed from white cell contamination, there is benefit. There's a benefit in the inflammatory response, and there's actually a benefit in reducing blood transfusion in cardiac surgery patients. There was a question at the end of the last speaker's talk about antithrombin 3. There is a recombinant antithrombin 3 product that's available instead of thrombate. Thrombate used to be a plasma-derived product. The recombinant form of antithrombin 3 is reasonable for heparin resistance. There may be some benefit prophylactically in patients who you suspect have some heparin resistance. For example, somebody that's been in the hospital before operation a long time, has been on heparin, they almost certainly have their AT3 stores depleted, and so it may be that if they need an urgent operation, it's reasonable to prophylactically give antithrombin 3 concentrates. And there is some evidence in the literature to support this. This is not, randomized controlled trial data. It's a class 2B recommendation. And then there are some new products that are available for, they're not really new products, they're really products that have been available for other specific indications, like factor VII was available for bleeding and hemophilia. But these are other products that were available and are now being considered for patients who have refractory bleeding. And these are the high-risk, high massive transfusion type patients, and usually, you throw the kitchen sink at them. But factor 13 is a clot stabilizing agent. Factor 9 containing products are very potent prothrombotic agents and have some efficacy in the refractory bleeding especially of cardiac surgery patients. And then there are some newer pieces of information about, I've been told I can't use the word cell saver because it's proprietary, even though I've been using it for the last 30 years. So I have to use cell salvage by centrifugation. But anyhow, this cell salvage has been expanded. And there used to be contraindications, for example, cancer patients and septic patients and things like that. And when you look at it, the evidence really supports using it in cancer patients because cancer patients do a lot worse if they get transfused. And so to save them from getting transfused actually comes up with a class 2A recommendation. And then there's some information about how you process pump blood at the end of the operation. And evidence supports using centrifugation of the residual in the perfusion apparatus. And that's a class 2A recommendation. And then platelet plasmapheresis can be used. And I guess Hemonetics has a machine that'll do that. And we certainly don't use it routinely, but it may be something to consider in the highest risk patients. The trouble is the patients you need this on the most are the sickest and don't have a high platelet count, and they're anemic, and you can't afford to do it. But it has some benefit when it's been tested. And again, the minimally invasive procedures have been shown in most cases to reduce bleeding and blood transfusion, especially in thoracic aortic operations. These are very high-risk operations associated with massive blood loss. In many cases, the endovascular repairs have been associated with much less bleeding, much less blood transfusion, and equivalent outcomes. Now, there may be some question about the long-term benefit of an endograft, but there's no question about bleeding. And same with off-pump procedures. The op-cabs have been shown to have less bleeding than regular on-pump operations. There's now some concern expressed in the literature about graft patency in the off-pump procedures, but there seems to be benefit in blood transfusion. And so here's sort of a summation of perfusion interventions that we've looked at and have found to be efficacious. So use of microplegia, mini circuits. I know there's going to be a talk about vacuum-assisted venous drainage, and I know that'll be controversial because it was amongst our writing group. But biocompatible circuits, modified ultrafiltration, all those things have been looked at and have some evidence to support them in the literature. The one thing that didn't prove to be useful was leukocyte filtration in the bypass circuits. But I'd like to hear your feedback from this. And then there's some interesting information about topical hemostatic agents. So there's been an abundance, a proliferation really of anastomotic sealants. There's the greatest one here is chitin, which is seashells, ground up seashells, But all of these things have been used and have some benefit. So it's kind of weak. The randomized controlled trials are very difficult to design, but they seem to work and provide some benefit. The interesting thing, I thought, was that there's evidence out there that if you make a slurry of aprotein or lysine analogs and you throw it in the pericardial well and you close the patient up, clamp the chest tube for a while, they bleed less. And when you think about it, it makes pretty good sense, because all of the coagulation and clotting cascade that was talked about in the previous talk is occurring locally in the pericardium. And so you're actually getting, instead of giving lysine analogs intravenously, you're actually getting it to the point where it's beneficial. So there were actually 2 or 3 randomized trials that did that. They poured lysine analogs or aprotein into the pericardium, closed the patient, clamped the tube for about an hour, and did that in a randomized, blinded way, and found benefit. So this actually comes up with a Class 2A recommendation. So the other thing that comes through here is that many of the perfusion interventions are interested in hemoconcentration or a lack of hemodilution. So things like mini circuits and ultrafiltration and pump salvage, all of those things are really trying to recover what is otherwise hemodilution from the heart-lung machine. And again, it's one of those things where multiple things add up to have a good outcome. So in our hypothetical little old lady patient, are there interventions that can help? Well, yeah, there's 61 of them from 2007, and now in 2010 there's 31 more. So there are evidence-based guidelines that can help in this high-risk patient. I wanted to briefly talk about one other thing that brings up some interesting points about who should manage transfusion. And this is a patient who's a post-op patient. So a 62-year-old man had a 3-vessel Cabbage. He had some drugs on board before operation. They were stopped appropriately. But 4 hours after operation, you're called, and he's bled 100 to 200 cc's an hour. His hemoglobin is 7. He's had 1,000 cc's of albumin and 1,000 cc's of crystalloid. So, I mean, should we even worry about this? Well, Bob Dylan knew the answer to that. He said, you better start swimming or you'll sink like a stone. So there's 3 things that can happen to this patient. 2 of them are bad. One is he can stop and that's fine. The other is he can stop all of a sudden and he tamponades and you're doing CPR and rushing him back to the operating room. Or the other thing is the next hour he'll have 500 cc's out of the chest tube. So this is the person who's on the cusp. He's bled 600-700 cc's in 4 or 5 hours. That's the person you have to worry about. You have to intervene at this point because something bad can happen. So there's some questions asked about this. Should you give him a transfusion? Hemoglobin 7, he's bled out 600 cc's. Is there an algorithm? An algorithm is a decision tree. It's how do you decide what to do based on information available. Is there an algorithm that tells us what to do? And then who should give the transfusion? Who should decide? Is there a team? Is there somebody that should decide about this? Well, I love this slide because it's blurry. But the other part is it's about red cells. It's about transfusion. This is what we give to patients when we say, let's transfuse them. And this is pictures of red cells, photomicrographs of red cells as a function of the time after they were donated. So day 1, the red cells are biconcave discs. They're easily deformable. They go through the capillaries. They give up their oxygen. They do what they're supposed to. 3 weeks later, they're not biconcave discs. They're not easily deformable. They don't give up their oxygen. 5 weeks later, they are not deformable. In fact, they plug up the capillaries. So if you were to transfuse somebody with 5-week-old blood, you wouldn't be getting what you think you're getting. So you might go to the blood bank and say, hey, I want day one. I want the best for my patients. The blood bank will laugh in your face. There's no blood bank in the world that has the policy of giving out the freshest blood first. In fact, if they know your patient's having heart surgery, they'd search through the blood bank and give the oldest blood deliberately because they know there's a high chance you'll use that blood before it expires. So it's probable that what we give when we give blood transfusion is not what we think we're giving. We know an awful lot more about the risks of blood transfusion, the disease transmission, the AIDS, the hepatitis, all those things, West Nile virus. We know a lot about the risk, nothing about the benefits, or very little about the benefits. Furthermore, if you look at what is the effect of a blood transfusion? Now, it's very hard to find a randomized trial about this because surgeons are unwilling to randomize a patient and have somebody come up to them and say, you can't transfuse that patient because he's in the random group that doesn't get transfusion. They're unwilling to randomize their patients. But you can look at observational data. And this is interesting because it's a cardiology study. So these are patients who had PCI. And you know, you've all seen this. Somebody comes into the OR for an urgent Cabbage and they have a huge hematoma in the groin. And there's at least 2 units of blood there. And you say, well, gee, we're already stuck. We've transfused this guy 2 units just to make up for what he lost in the cath lab. Well, if you look at around 5,000 patients who've had a PCI, and you say, well, what determines how their outcome at 1 year? And this is a mortality study, 1 year mortality. And you would think that the determinants of mortality at 1 year in a patient with a PCI would be ventricular function, the size of the MI, you know, cardiac things. Well, it turns out that if you had significant bleeding, that was the most important determinant of outcome at 1 year in a patient with a PCI. It's pretty strong evidence, and there's actually a lot more studies in the literature to corroborate this observation. Not randomized controlled data, but there's evidence that bleeding is bad, and it translates to worse outcome. So there are 2 bad things about blood loss and bleeding, postoperative bleeding. One is the loss of the blood, and the other is the transfusion, what you have to do about it. So in our hypothetical bleeding patient after operation, will this patient benefit from a transfusion? Well, if he was a Jehovah's Witness, you'd say no. There's lots of evidence out there of Jehovah's who bleed down to a hemoglobin of 4 or 5 and live. So it's not quite clear that you absolutely need to transfuse and what the threshold is. And it's pretty clear that blood loss is bad, but so is blood transfusion. So will this patient benefit? Maybe. It's one of those things that generates hypotheses. And it is an uncertainty. And whenever you see something like this in medicine, that doesn't inhibit anybody from writing guidelines. But, and this is, for example, what the anesthesiologists have done. So this is how to decide about a transfusion. And the key word here is consensus. So whenever you see that in a guideline, that means there's no evidence. That means a bunch of experts got together in a room and decided what they're going to do. Now, most of the time it's reasonable, but there's no evidence. So these are the consensus guidelines. And I think you'd look at it and most people would agree that's what we do. This is a good thing to do. So if you're on bypass, your hemoglobin 6 or less, you give a transfusion in most cases, especially in an older patient who's high risk. And then in the ICU, hemoglobin less than 8, you might start thinking about a transfusion. If your hemoglobin's greater than 10, you don't transfuse. And somewhere in between, it's up in the air. It's individual. There really isn't good evidence to back you up. And then what about non-red cell hemostatic factors, platelets, cryoprecipitate, plasma. Well, the fact is there's no evidence. There's no randomized controlled trials. In fact, there's darn little consensus. Most people would agree that you transfuse these factors if you have a bleeding patient. If you're not bleeding, there's probably not an indication for it. And that's even true for cancer patients whose platelet count drops down to 10,000. They still would not transfuse those unless they're bleeding. This is where point-of-care tests can help. So when we went to the literature to try and sort out how do you decide about a post-operative patient getting a blood transfusion, I was surprised. I mean, we found 7 randomized controlled trials that had tested whether a transfusion algorithm, remember an algorithm is a decision tree, tested whether that supplemented with point-of-care testing. Now, point-of-care testing is at the bedside, something that you can get pretty much right away. And it can tell you, is your platelet count low? Do you need to give plasma? You know, if you get the right test, it's something that gives you that instant feedback that helps you in your algorithm. So 6 of the 7 randomized trials showed a benefit from using an algorithm-driven transfusion mechanism along with point-of-care testing. That was the good news. I was surprised that we found, by the way, when you find a whole bunch of randomized trials about the same thing, they almost never agree. So when 6 of 7 agree, that's a good thing. So that was impressive. Now, that was the good news. The bad news is all of them had a different algorithm, and all of them used different point-of-care tests. So it didn't seem that it was so much what your trigger for transfusion was, as much as it was that everybody agreed that this is who we're going to transfuse. So it was the decision support that was the key thing. And as I said, a whole bunch of point-of-care tests were used. There weren't just one thing. Here was one of the studies. So 210 patients randomized. Here's the algorithm they used, the point-of-care tests they used. So if your hemoglobin was less than 8, you got a transfusion. If the PFA 100 is a platelet function analyzer, if that was abnormal, these are post-op algorithms, and if the PFA was abnormal, they gave a dose of DDAVP, and if that didn't work, they gave platelets. And then they were still using a protein, and they used the TEG amplitude, which is supposedly an indicator of fibrinolysis. They gave a protein. And then an important part of blood conservation was early exploration. So if none of these things worked, took the patient back to the operating room. Because none of these things will work if you got a hole in the artery. And furthermore, early exploration is a blood conservation intervention. Because if you sit there and pour blood products in, and then you go back, you've transfused a lot and bought into all the side effects of the transfusion. So in this randomized trial, when they did this, they found decreased transfusion in the algorithm-driven group and equivalent safe outcomes. And that was important evidence. So in our post-operative bleeding patient, is there an evidence-based transfusion algorithm that guides therapy? Yeah, there is. And it doesn't matter what you use, it's just so everybody agrees on it. And then, so one of the things we've wrestled with for a long time is we go to a lot of work, a lot of effort to make guidelines, and then nobody adheres to them. So why not? And this is a big part of the guideline process now. It's trying to decide how to get people to buy into the guidelines, to do evidence-based medicine. Well, there's a great article by a group of psychiatrists, of all people, who've looked into why surgeons and why people don't adhere to guidelines. Interesting things come up. So it's failure to recognize the value of teams. What do I mean by that? Well, if you think about it, the decisions that go into taking care of a patient after an operation or during an operation are not just one person's decision. There's an ICU nurse, there's a perfusionist, there's an anesthesiologist, there's a whole bunch of people who make decisions about that patient. So the old idea of one-on-one doctor, I'm the king of the ship and all that stuff, that's gone. Those days are gone. And that's important. that seems to be one of the things that translates into not recognizing and not doing evidence-based medicine if you don't understand the value of teams. Unfamiliarity, you just don't know the information that's presented in most guidelines. Surgeons are functionalists. We need to see the results of what we do. That's why we went into surgery. It's pretty hard to see the benefit of not transfusing somebody. You might not see it for years, but it's a reason why we don't adhere to evidence-based guidelines. And then natural validity. Natural validity means the resident does what you tell him. And then pretty soon he's accepted that as the standard of care. And then he goes on and accepts, and when he becomes an attending, he tells the same resident the same thing. So that's natural validity. And then there's inevitably the person who says, these guidelines are crap, I don't believe any of it. Well, that's just the way it is. I don't know that we'll ever change that. And then the recommendations run counter to what's been done in the past. How many times have you heard that? We do it this way. Well, we used to transfuse people when the hematocrit was 30%. I'm old enough to remember that. Well, geez, if you transfuse somebody whose hematocrit is 30% now, you're dumb. So this is getting at who should decide about a transfusion. And as I said, the one-on-one doctor-patient relationship is gone. Very few practitioners adhere to guidelines, and it's partly a result of failure to recognize that care providers are diffuse. And it's really a healthcare team. And believe me, I'm as old as anybody in this room probably, and I've had trouble accepting this because I grew up when the surgeon in the operating room screamed and yelled and threw things, and that's kind of the way it was. But in truth, people that make decisions about patients are not necessarily the surgeon. An example of that is I can't remember the last time I wrote an order for a blood transfusion. Does that mean I never transfuse my patients? No. It means the resident does it, the intensivist does it, the anesthesiologist does it, the perfusionist, somebody else writes the order. So for me to think that I, as the surgeon, am deciding who gets a blood transfusion is crazy. It's not true. So we clearly don't recognize the value of teams. Key patient events are not supervised by the surgeon. That's just the way it is. We have to accept that. Multidisciplinary teams make better decisions, and there's pretty good evidence in the literature to support that. So in our bleeding patient, who should decide about transfusion? Well, the team should. And a team is different in every hospital, but it clearly should be the team. Oh my God, what did I do? Okay. Okay, so take-home message. High-risk patients. Risk assessment is important. Multimodality approach is best, especially with a team-based, algorithm-driven blood management program. Benefits of blood transfusion may not be as great as we think. There's clearly a variable response in everything that we do. It's probably most prominent in Plavix, but it's there. And then guidelines oftentimes identify deficits, and they're hypothesis generating. So implications: control blood loss, salvage, sequester, hemoconcentrate, transfuse with caution. Medical teams make better decisions. That's all I have. I'd be glad to answer questions. In fact, I'd solicit any questions you have.